if there is no enough time, you can meet the speakers and ask him directly. Next lecture would be provided by Dr. Aya Shukry, Director of MRI, and will speak about the visual language of CNS vasculitis, what radiologists need to know. والدكتورة أماني الحقيقة كانت المفروض تبقى موجودة تشير بيرسون بتاعت الديبارتمنت، وهي بتعتذر عن التواجد لأنها عندها ارتباطات في الدمرداش. اتفضلي يا دكتورة أي.
Good morning. احنا هنتكلم عن الفاسكوليتيز و what the radiologist should know. أول حاجة, the vasculitis are a heterogeneous group of inflammatory diseases that affects the blood vessel walls and compromise the lumen and thus causing tissue ischemia. The first reports about vasculitis were as early as the late 1800s by Ferdinand von Hebra, followed by Adolf Kosmol. They reported cases of polyarthritis nodosa specifically. The CNS vasculitis are either primary, that are totally confined to the CNS with the patient otherwise completely free, or secondary as a part of other systemic inflammatory, infective, or autoimmune processes. The incidence is, of course, much commoner with the secondary causes of vasculitis. The diagnostic challenges in cases of CNS vasculitis are related to their being rare and at the same time life-threatening, with no strict age or sex predilection. However, the primary CNS vasculitis are more reported below the age of 50 and among males. Clinical manifestations are non-specific, with the headache being the most common, and the imaging pattern is rather variable, with white matter hyperintensities being almost always there in the MR imaging. Differential diagnosis is also wide, and we will report some cases of vasculitis. The clinical presentation, at first, the onset is usually insidious and slowly progressive. However, acute beginnings in the form of like seizures or focal neurological deficit can also occur. The presence of constitutional symptoms is rare and usually refers to causes of secondary vasculitis. A whole panel of laboratory tests is usually ordered in order to exclude the secondary and autoimmune causes of CNS vasculitis. So this is the role, and also to identify the disease activity, however, not specific for the CNS vasculitis itself. The brain biopsy is the gold standard for the diagnosis, requiring sufficient sampling to include the small vessels, taken from an area preferably abnormal on MRI, and if random sampling is inevitable, it's usually taken from the non-dominant frontal lobe in order to minimize the neurological deficit later on. The biopsy reveals transmural involvement of all layers of the blood vessel wall changes ranging from the inflammation early up to necrosis, and exclude other non-inflammatory causes of blood vessel disease. The risks of invasiveness and complication is there, with low sensitivity as low as 30 to 50%, which we try to increase by including a sufficient sample, as we said earlier. Early steroid treatment of the patients before the biopsy being taken also compromises the results. Radiographically, the cerebral angiography is the gold standard for the imaging, including the digital subtraction angiography, CT, and MRI, with the later two being less sensitive compared to the digital subtraction angiography. The angiographies are more sensitive with the vasculitis involving medium-sized and large-sized vessels, and less sensitive with the small-sized vasculitis, usually appearing as segmental stenosis involving multiple cerebral arteries, followed by focal dilatation, giving that beading appearance. Arterial occlusions and aneurysmal dilatations are rather uncommon. MRI shows white matter lesions that are almost always there, with normal MRI making CNS vasculitis very unlikely. These white matter lesions in the T2 and the flare are usual bilateral, diffuse, discrete to confluent white matter lesions. Also, recent infarcts together with older infarcts, so infarctions of variable ages, are a common presentation in the CNS vasculitis. Parenchymal hemorrhages, ranging from the more prevalent solitary microhemorrhages to a combination of micro and macro hemorrhages, is also a common presentation. Subarachnoid hemorrhage is rather uncommon in CNS vasculitis. Post-contrast enhancement, from the more prevalent dot linear pattern and nodular pattern down to the perivascular and patchy leptomeningeal enhancements, are also a presentation. Vessel wall enhancement, rather the specificity for identification and the follow-up is still unestablished. However, it gives an idea about the disease with segmental, concentric, and homogeneous enhancement of the involved blood vessel wall. Also, the disease follow-up usually shows regression of the enhancement with favorable response to the treatments. This is why it's not specific nowadays, because atherosclerosis, dissection, moya-moya, and reversible cerebral vasoconstriction syndromes all show different patterns of enhancement of the blood vessels on the high-resolution vessel wall imaging, being more of eccentric in atherosclerosis and dissection, concentric similar to the vasculitis in the moya-moya and the RCVS. Also on follow-up, atherosclerosis, only 30% show regression, dissection too. For the moya-moya, it's usually progressive enhancement, regressive on treatment with vasculitis, and spontaneous regression is to be expected in the RCVS. A typical MR presentation include large solitary white matter lesion with extensive surrounding edema and effacement and mass effect, and peripheral enhancement is there in this tumefactive tumor-like primary angiitis of the CNS. However, those patients usually show negative results on digital subtraction angiography or any angiography, which suggests the predominance of small vessel disease. For the differential diagnosis, we will go through some cases involving, for example, this 46-year-old female presented with acute onset of left facial numbness and dysarthria. The patient is otherwise neurologically free. The labs show elevated CSF level of protein and anti-nuclear antibody titers, as well as anti-cardiolipin M. Her imaging show an acute infarction in the left MCA territory. Also, left MCA, right PCA, and right internal carotid artery segmental narrowing, with the high-resolution post-contrast MR of the blood vessel wall show evidence of old infarcts on the right, evidence of subacute enhancing infarction on the left, and an enhancing, like here, an enhancing concentric MCA wall. So the patient is a middle-aged female with focal neurological deficit and the infarcts of different ages, beading and narrowing on angiography and concentric vessel wall imaging with evidence of inflammatory and autoimmune elevated markers. It is a case of systemic lupus erythematosus complicating CNS vasculitis, a lupus vasculitis. The patient was treated with steroid therapy, pulse steroids for 3 days. Other systemic causes that may involve the CNS include large vessel vasculitis and medium-sized vessel vasculitis, small vessel vasculitis, with the most common being the giant cell arteritis, the polyarteritis nodosa, and the Kawasaki disease. A child of 7 years that was presented by fever, irritability, agitation, and episodes of vomiting only developed the same morning. Neutrophilic leukocytosis and increased inflammatory markers with CSF proteins were seen on the lab work, and the mother stated recent chickenpox infection few weeks earlier. The patient the MRI showed a rather massive hemorrhage involving the left middle cerebellar peduncle and cerebellar hemisphere, with the angiography showing multiple beading appearance of the vasculitis. So this is a child with constitutional symptoms, recent viral infection in history and agitation. The MRI show macrohemorrhage, beading and narrowing on angiography with elevated inflammatory markers. So it's a case of varicella-zoster vasculitis. Other infections and pathogens are also involved, with the most commonly the bacterial meningitis by the strep pneumoniae, also the herpes pathogens, varicella zoster, Epstein-Barr, cytomegalovirus, and herpes simplex type 1, and the retroviruses like the HIV viruses, fungal infections as the aspergillus. Another is a 28-year-old woman that is presented by acute onset of numbness and paresthesia on the right side of her body and face. The patient is a known Graves' disease uncontrolled. The CSF shows mildly raised proteins, otherwise neurologically normal, and the thyroid profile is proven by labs. The patient showed multiple microinfarcts, multiple acute microinfarcts distributed bilaterally on diffusion-weighted imaging. Also, the MR angiography and the digital subtraction angiography showed bilateral supraclinoid internal carotid artery narrowing, which showed also circumferential enhancement in the vessel wall imaging. So it is a female patient presented with a neurological deficit with known history of uncontrolled Graves' disease, showing bilateral watershed infarcts, supraclinoid ICA narrowing, and concentric circumferential wall enhancement, elevated CSF proteins. This is a case of CNS vasculitic moya-moya syndrome in association with Graves' disease. The patient was treated by carbimazole and intravenous steroids, and she remained relapse-free for a period of 6 months. A 58-year-old male patient that is presented with dizziness, his being diabetic, hypertensive, and heavy smoker for more than 30 years, with elevated serum level of hemoglobin A1C, cholesterol, and abnormal lipid profile with inflammatory markers. The MR angiography showed left MCA narrowing with a proton density showing a peripheral eccentric atherosclerotic plaque. The plaque is eccentrically enhancing on vessel wall imaging. So the patient have many comorbidities for atherosclerosis. He's an old-aged male with risk factors, showing the classic beading narrowing with a detected enhancing plaque and abnormal labs to prove that. So it is a case of CNS atherosclerosis. The plaque enhancement on vessel wall imaging in cases of atherosclerosis usually involves the fibrous cap and the adventitia, and the enhancement was reported to be the most reliable indicator of an unstable vulnerable plaque. 33-year-old woman that is presented with a sudden onset of elevated blood pressure and a thunderclap headache few days postpartum. That thunderclap headache exacerbated on lying down and decreased on standing or sitting. Surprisingly, this patient was totally normal radiologically in the 3rd day after the presentation. The MRI was normal, the angiography was normal. By the 10th day, she developed the classical appearance of the beading and narrowing involving multiple blood vessels. And by the 43rd day, it was totally resolved. So the thunderclap headache is rather pathognomonic, the postural too. The early normality and non-contrast with the later appearance of the manifestations and the spontaneous recovery later on with the patient otherwise being normal is an indication of irreversible cerebral vasoconstriction syndrome. This is another example for a case showing that classical beading appearance on angiography and enhancement, and on follow-up later on, up to 7 years follow-up showed total resolution of the beading as well as the enhancement. Our last case is a 31-year-old woman that is presented with a continuous, rather mild to moderate intensity headache for a period of 15 days, followed by signs of lateralization with left upper limb and lower limb weakness and slurred speech. The patient showed a right MCA territorial infarction, as well as the classical beading appearance on the angiography with the enhancing. Here's the affection is on the right side. This is thickened and narrowed and showed enhancement too. With the left side, that's the normal side. So the patient is a middle-aged female with mild headache and focal neurological deficits, showing acute infarction, beading and narrowing, and concentric wall enhancement. Every other single lab test or manifestation is completely normal. Patient is otherwise free. So this is, by exclusion, a case of primary CNS vasculitis. The patient was treated by injection of steroids for 5 days, followed by oral steroids and insulin. Later on, cyclophosphamide as per the protocol. The patient didn't have any recurrence through a year. So for the reporting, firstly, we have to state clearly the dedicated CNS vasculitis protocol to be used. We have to characterize the lesions, the location, age type of the parenchymal abnormalities as detailed. The vascular findings also can be described meticulously through the MRA and the high-resolution vessel wall imaging and enhancement. Suggest a differential diagnosis to be taken and correlate with the clinical context to avoid other differential diagnoses. Thank you.